Good day, everyone. This procedure is a variohysterectomy or the Spay cut. So the surgeon was Miss Carriazo, assistant surgeon is Miss Cañero, nurse Miss Marzo, and anesthesiologist was Miss Sobrevilla. For the introduction, first we had Spay. Spay refers to a variohysterectomy or the surgical removal of the ovaries and the uterus. So, signalment. Our patient's name is Kitty Feliscatus, a 1-year-old female, about 2 kilos, and a tricolor. For the indication of this procedure, it is used for the birth control, pyometra, metritis, neoplasia, like for example, ovarian, uterine, or vaginal, cysts, uterine torsion, uterine prolapse, and vaginal hyperplasia. Anatomy. So as you can see, there is a illustration at the side. So first, the female reproductive tract includes the ovaries, oviduct, uterus, vagina, vulva, and the mammary glands. The ovaries are located within a thin-walled peritoneal sac. The ovarian bursa is located just caudal to the pole of each kidney. The uterine tube or oviduct courses through the wall of the ovarian bursa. Each ovary is attached by the proper ligament to the uterine horn and via the suspensory ligament to the transversalis fascia medial the last 1 or 2 ribs. The suspensory ligament is a tough, whitish band of tissue that diverges as it travels from the ovary to attach to the last 2 ribs. The uterine arteries and veins supply blood to the uterus. The cervix is constricted caudal part of the uterus and is thicker than the uterine body and vagina. The vagina is long and connects with the vaginal vestibule at the urethral entrance. For the clitoris, it is a broad, flat, vascular infiltrated with fat and lies on the floor of the vestibule near the vulva. The clitoral fossa is a depression of the floor on the floor of the vestibule that is sometimes mistaken for the urethral orifice. Lastly is the vulva. It is the external opening of the genital tract, and the vulvar lips are thick and form a pointed commissure. So before the operation started, we had first fasty cut, patient preparation, skin preparation by clipping the hair, surgical positioning, IV fluid hydration, anesthesia, and the patient monitoring. For the operative technique, first, for the ovariohysterectomy, elevate the abdominal wall with thumb forceps and slide the ovariectomy hook against the abdominal wall, 2 to 3 caudal to the kidney. Exteriorize the uterine horn with the hook and identify the suspensory ligament at the cranial edge of the ovarian pedicle. Stretch or tear the suspensory ligament to allow exteriorization of the ovary using the index finger to apply caudolateral traction on the suspensory ligament while maintaining caudomedial traction on the uterine horn. Place 2 Carmat's forceps across the ovarian pedicle proximal to the ovary and 1 across the proper ligament. Remove the most proximal clump and place a figure 8 ligature at the site. Next is direct the blunt end of the needle through the middle of the pedicle. Loop the suture around one side of the pedicle, then redirect the needle through the original hole from the same direction, and loop the ligature around the other half of the pedicle. Securely tie the ligature. Place a circumferential ligature proximal to the first ligature, then place a hemostat on the suspensory ligament near the ovary. Transect the ovarian pedicle distal to the clump across the ovarian pedicle. Next is separate the broad ligament from the uterine horn, clump and ligate the broad ligament if it appears vascular. Close the abdominal wall in 3 layers. First, the fascia or linea alba, subcutaneous tissue, and the skin. Okay, so in this illustration, first we incise the skin and then blunt the muscles. Then next is we isolate the uterus and the ovaries. Okay, so we also clamp the ovarian pedicle proximal to the ovary, then ligate the all the blood vessels in order to um, secure, and bleeding will not occur. And then next is we close the muscle layers, subcutaneous muscle layers, which we use PGA. For the subcutaneous we use chromic, and for the intradermal is chromic also, and for the skin is silk. For the post-operative technique, we use D5-LRS, sulfonamic acid, as an analgesic, anti-inflammatory, and antibiotic. Okay, so for the complications of this procedure, wound dehiscence may occur, stump pyometra, swelling, hemorrhage, peritonitis. For the IV fluids or the drug computation, first, for the pre-anesthetic, we use atropine sulfate. So for the computation, 2.25 kilos times 0.044 milligram per kilogram divided by 0.65 milligram per ml, so 0.15 ml. We use 0.15 ml of atropine sulfate. Anesthetic, we use xylitol 50, 2.25 kilos, 10 milligram per kilogram, 50 milligram per ml, and we use 0.45 ml of the xylitol. For the maintenance, 65 ml kilogram per day and 2.25 kilos, so 146.25 ml per day. For the replacement fluid, 2.25 kilos times 0.03 times 1000, 67.5 ml. The total fluid, 146.25 ml plus 67.5 ml, 213.75 ml. For the drip rate, so 213.75 ml divided by 24 hours, it will be 8.91 ml per hour. For the drops per minute, 213.75 ml divided by 6 hours times 60 drops and 60 minutes drops per hour, 35.61 drops per minute. Drops per second, 36.61 drops per minute divided by 60 seconds, we have 0.6 drops per second. For the intraoperative medication, we use tranexamic acid, so 2.25 kilos times 15 milligram per kilogram divided by 100 milligram per ml is equal to 0.3 ml. For the post-operative medication, we use pen strip, and it is 0.3 ml. And for the tolfenamic, 2.25 kilos times 4 milligram per kilogram divided by 40 milligram per ml is 0.2 ml. So that's all for my report. Thank you for listening.